Exactly how we're breaking it down today. First, the ATLS shock classification, then management by class. After that, we'll hit some high-yield clinical pearls, look out for classic exam traps, and wrap it all up with a quick recall challenge.
Okay, kicking things off with Section 1, ATLS shock classification.
Now, there is a super important physiological pattern to recognize here. Basically, as we move through the 4 classes of shock, I want you to watch what happens. As blood loss goes up from less than 15% in Class 1 all the way to over 40% in Class 4, that heart rate climbs aggressively. It goes from a pretty normal resting rate under 100 up to the 100 to 120 range in Class 2, pushes 140 in Class 3, and then just absolutely skyrockets over 140 in Class 4. But here is the real kicker. While that heart rate is spiking, the blood pressure and urine output, they are rapidly dropping off. Notice how blood pressure stays totally normal in Class 1 and is usually still normal in Class 2 before finally taking a nosedive in Class 3. Meanwhile, your urine output is plummeting from a healthy 30+ mils an hour down to basically a trickle.
So the big takeaway here is that by the time a patient actually hits Class 4, they've lost over 40% of their total blood volume. Just to put that into perspective, for the average adult, that is literally more than 2 liters of blood lost. This leaves them with a severely tanked blood pressure, little to no urine output, and a heart rate racing over 140. Guys, this is life-threatening shock with severe cellular and organ dysfunction. You are officially in the ultimate danger zone here.
Moving right along to Section 2, management by class.
Now, our interventions have to aggressively escalate right alongside the patient's deterioration. Think of it like a ladder. It's step 1 for Class 1, you're focused on source control, and honestly, simple crystalloid fluid replacement usually does the trick. But stepping up to Class 2, now you're controlling the hemorrhage and starting fluid resuscitation, but you got to keep in mind that blood products might actually be needed, depending on the ongoing bleeding. Then we hit step 3, and this is a massive paradigm shift. For Class 3 shock, early blood product resuscitation is an absolute must. You're activating that massive transfusion protocol and securing urgent hemorrhage control. And finally, step 4 for Class 4. This is a literal race against the clock. We're talking immediate, aggressive resuscitation with balanced blood components, definitive hemorrhage control, and very likely rushing straight to the OR for damage control surgery.
Let's shift gears to Section 3, high-yield clinical pearls.
Listen, if you take absolutely nothing else away from this explainer, let it be this one golden rule. Tachycardia is an early sign of shock, but hypotension is a dangerously late sign. I really cannot stress this enough. If you're standing around waiting for that blood pressure cuff to read low before you do something, you are already falling way behind. The heart rate is going to wave a giant red flag way before the blood pressure actually drops.
To build on that, you might be wondering, well, why does the blood pressure stay normal in Class 1 and Class 2? It's all about compensatory vasoconstriction. The body is literally clamping down on those vessels to maintain pressure. Because of this, you really need to be watching for a narrowing pulse pressure. That's your direct clue that the sympathetic nervous system is kicking into overdrive. Also, never forget that urine output is your best real-time marker for renal perfusion. A dry Foley catheter? That is a screaming siren telling you the kidneys are starving for blood. By the time you get to Class 3 and 4, those compensations have totally failed and you're dealing with severe tissue hypoperfusion and overt organ dysfunction.
All right, on to Section 4, classic exam traps.
Okay, do not fall for this classic trap. Examiners love to test if you'll classify shock by blood pressure alone, or if you'll just assume a normal BP means the patient is safe. In the real clinical world, a patient can lose a massive, life-threatening amount of blood long before they actually become hypotensive. Relying on a normal blood pressure reading to rule out major hemorrhage, that is a guaranteed way to miss a deteriorating patient.
Plus, you've got to remember that your patient isn't a textbook robot, right? The ATLS classification is an amazing framework, but it is not absolute law. A patient's response is going to vary wildly based on stuff like their age, whatever medications they happen to be taking, pregnancy, their athletic conditioning, and underlying comorbidities. Like, think about a young marathon runner. They have incredible cardiovascular reserve and might not even show early tachycardia. Or an older patient on beta blockers. They might be chemically blocked from mounting a tachycardic response at all. You always have to treat the unique individual right in front of you.
Finally, Section 5, quick recall challenge.
Let's put all this together and test your knowledge. Imagine a trauma patient comes in with an estimated 35% blood loss. Their heart rate is sitting at 130 beats per minute, they are clinically hypotensive, and their urine output is a meager 10 milliliters an hour. What is the exact diagnosis? Go ahead and lock in your answer in your head right now before I give it away.
Did you get it? The answer is Class 3 hemorrhagic shock.
This patient fits perfectly right into that 30 to 40% blood loss window. They've got a heart rate between 120 and 140, their blood pressure is demonstrably decreased, and they're showing that dangerously low urine output of 5 to 15 mils an hour. If you nailed that, your revision is absolutely on track.
So now that you've got the textbook classification down cold, I'm going to leave you with one final question. How will you adjust this mental framework when your very next trauma patient is heavily medicated, or pregnant, or happens to be an elite athlete? For instance, how exactly does the expanded blood volume of pregnancy alter these classic signs? Keep that provocative thought turning over in your head as you head onto the wards or sit down for your exam. Let it push you to look just a little bit closer at every single patient. Thanks for joining me for this explainer, and keep that focus sharp.